Could AI help you do more of what you love? Workday is the AI platform for HR and finance that actually knows your business. We help you handle the have to-dos so you can focus on the can't wait to-dos. It's a new Workday.
Adobe Firefly is the all-in-one creative studio with AI-powered image and video editing for today's creative process. Built for creators of every kind, Firefly helps you generate, edit, and experiment fast. Because the asks aren't getting smaller, the budgets aren't getting bigger, and the timelines, oh yeah, still tight. With all the best creative AI models in one place, Firefly brings your ideas to life. Unlock a better way to make with Adobe Firefly.
This is Addiction Medicine Journal Club. I'm Dr. John Keenan.
I'm Dr. Sonya Tredici.
And I'm Dr. Anthony Accurso.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. This episode, we're switching up a bit and highlighting research posters from the recent American Society of Addiction Medicine conference. Sonya, do you want to tell our listeners a little bit about what a poster is, since it's a little different than what we normally do?
I sure do, John. Yes, this is a little different. So for those of you who haven't been to a conference recently, a research poster is a summary, like a short, concise summary of your research. It's usually presented at a meeting, a scientific meeting, prior to it being published. There are often new findings, small projects that don't quite, raise the bar or raise to the level of publication. But just because something is presented on a poster doesn't mean that it's low quality or unimportant. Tons of research is spread through posters. And having just come back from the amazing poster session at ASAM, we wanted to share some of this research with our audience as well. And just a quick note, we offer CME for our other podcasts, but we are not offering CME for this episode. But if you want CME for other episodes, you can get it from the show notes and our website. So before we go on, our regular listeners will have noted a third person on the recording or on the podcast, Dr. Anthony Accurso. So Anthony, you want to introduce yourself to the audience?
Sure, Sonia, and thank you both for having me on the show. My name is Dr. Anthony Accurso. I'm the Medical Director of Addiction Medicine at Bergen-Newbridge Medical Center in Paramus, New Jersey. And in that role, I'm responsible for both a large ASAM Level 4 medical withdrawal management facility, what we might call medical detox. And I also have an outpatient office-based addiction treatment and primary care practice, which is also a low-barrier bridge clinic.
So you're like a real addiction medicine doctor.
Well, so I trained in internal medicine and primary care. I would submit I'm surrounded by two excellent addiction medicine doctors as well on this call. But I trained in internal medicine and then was placed in the Division of Chemical Dependence early in my residency and sort of learned the craft there and then certified in addiction medicine in 2016.
Never look back.
Never look back.
Now, part of the reason we wanted to have you on this podcast, as well as Anthony was my partner in crime for a workshop we gave at ASAM on benzodiazepine tapering last month, but also his poster at ASAM won the prize for the best overall poster at the conference, beating out 186 other posters from all over the country, from all kinds of fancy universities and other places. And so we thought he'd be the perfect person to join us to talk about poster research. Yeah, we're in the presence of greatness here. Poster greatness.
That's it. Sonia, you really know how to make a poster sound like real something. I really appreciate that.
I don't know. Out of 187, that's pretty amazing no matter what it is, right?
Yeah.
I did have a funny moment in February. I got an email from American Society of Addiction Medicine. I was sitting in the TV den, and it said, congratulations, your poster was chosen as best overall poster. And I came running out of the den, and I sort of yelled at my wife and kids. It's like, oh my God, we won the science fair.
Yeah, exactly. You do a trifold where it stands up.
That's right. Like my bread mold experiment won the science fair. Anyway, no actual bread mold was used to do the science project.
That's funny.
So with that said, do you want to lead us off by talking about your poster, Anthony?
I'd be delighted, Sonia. Thank you. So our poster was called Lower 30-Day Readmissions Noted after long-acting buprenorphine injection in a co-located Bridge Clinic withdrawal management unit. This poster was a retrospective look back at 3 years of work, or at the time we did the poster, 2.5 years of work in a busy county hospital setting, safety net hospital setting. And we really benefit from the fact that we have a hospital-grade 50-bed withdrawal management unit in the same building as a low-barrier bridge clinic. And so you can imagine that lets us do all kinds of things like start buprenorphine on patients in the hospital and then catch them in the bridge clinic. It also allows, since the hospital is so large, we're able to buy and bill long-acting injectable buprenorphine. So the hospital is willing to buy, 10 or 20 shots ahead of time, which is, a $10,000 outlay. But a county hospital has enough volume that it's able to do that. And so this allows us to be pretty nimble with the long-acting injectable buprenorphine shots in our bridge clinic. And so we started giving these shots about 3 years ago. And what we realized is if a patient comes in fentanyl dependent to our medical withdrawal management facility on a Monday, say, that gives us about 3 nights to transition them from a fentanyl state. We'll use methadone on the first 2 nights, buprenorphine on the second and third nights, and get them transitioned to buprenorphine. But on that first day when they come in, we also alert the prior authorization team to try to get started on the long-acting injectable buprenorphine. And so when that all lines up nicely, right when the patient is getting discharged from our unit, taking the scrubs off, putting their clothes back on, getting their belongings, then they discharge down to the outpatient clinic. And one of us is working there every Monday to Friday and can administer a long-acting injectable buprenorphine shot and bill the insurance for it.
Oh my God, it's such an administrative dream.
We feel very lucky to have like such a setup. But now, mind you, this is not a frequent occurrence. It's more like a home run in baseball. And so just for context, in the time period of the study, we looked at 5,622 visits. And out of all of those, we pulled off this maneuver 75 times.
Mm-hmm.
So what we decided to do is we wanted to explore on this poster, once we do place a long-acting injectable buprenorphine shot in somebody, does that seem to have any influence in their 30-day readmission rate? And so it turns out that opioid-dependent people get readmitted to our facility at a pretty constant rate. And so we set about looking first into 2 groups of people. We looked at people who never asked for a shot, and we looked at how often they get readmitted. And then we looked at people who did at some point ask us for a shot, and we looked at how often they were getting readmitted before they took the shot. And then we looked at how often they would be admitted within 30 days after they got the shot.
So people like served as their own controls.
That's right. So we kind of had 2 control groups, people who never asked us for a shot, and then people who did ask for a shot, but before the shot, they're their own controls, just like you said, Sonya.
That's like the gold standard for like in a controlled trial is the people are their own controls, because then there's no difference in the 2 groups, as it were.
The results of our study, we had 5,622 visits, 3,000 individual patients. And so most people never got a shot. So 5,147 people never got a shot. And their readmission rate turned out to be 13% at 30 days.
Not bad.
We then looked at people who did get a shot, and there were 474 admissions for people who had ever gotten a shot. So that's not 474 shots, but that means that of everybody who got a shot from us, they had been in the hospital 474 times overall. And so we looked at their readmission rate before they got a shot, and it was 19.6%. And we looked at their readmission rate after they got a shot, in the 30 days after they get a shot while they're leaving the unit, and it goes down to 6.8%.
Ooh, so 19.6% to 6.8% readmission rate once they got the shots.
That's right. And so we calculated an absolute risk reduction of 12.8%, or a number needed to treat of 7.8 to prevent a readmission. And that was statistically significant with a P of 0.005.
Would you assume that a lot of people leaving your detox would have sublingual or transmucosal buprenorphine?
Yeah,
So
and many
that's,
many of them do. Yeah, we didn't account for that in the study, but
but it's like, right, it's kind of like that's what you're comparing it to, as opposed to nothing.
interesting. That's another study that we'd like to do, Sonia. And in fact, actually, we're sort of looking at submitting that to a MRSA. But it turns out that actually a lot of people who come in to see us say, please quote, detox me off of all opioids, and I just want to go to rehab somewhere. Just send me to the Salvation Army, or send me to a short-term residential rehab facility somewhere. And we pitch medications for opioid use disorder pretty hard. We suggest to people, if they are housed and live near a methadone clinic, an OTP, that they might want to try to start methadone. If they tell us that, we'll start them on it. We do offer a cross-taper protocol, which I could discuss with you a little later. And that allows people to start buprenorphine. And then we offer people sort of taper to nothing. And when we looked back at this, we now have just about 50 or 60% of people who are opioid dependent coming in asking us for some kind of opioid agonist therapy, either buprenorphine or methadone. And about 40% who say, thanks, but no thanks.
That's surprising. I feel like that number is not as high as I would think.
I don't know. It's like, it's such a project to be on methadone or buprenorphine. It seems low key to us because we do it every day, but it does involve a certain amount of, I don't know, appointments, doctor stuff. You're like stuck having to talk to the man about your drug use all the time.
No, just surprising me in that setting. You think they would kind of select for a group more interested, but I guess, what do I know? It's wrong.
I sort of say, we addiction medicine doctors, we're still all on different parts of the addiction elephant. And some of us are feeling the leg and thinking it's a tree, and some of us are feeling the trunk and thinking it's a hose and whatever. But, I actually, when I used to work in an office-based addiction treatment facility in Brooklyn, I thought buprenorphine was just the answer. Like why doesn't everybody just take buprenorphine and like that should be the end of the story? But there's like a big selection bias there, because the people who are coming to see us in buprenorphine clinic are the people who like buprenorphine and like doctors, and that's really not everybody.
Yeah.
What are you saying?
So what, when we look at the people who approach a medical detoxification facility or withdrawal management facility, it's a little bit more of like people from different sides of the elephant. So
interesting.
I mean, I just think it's great. We've been working on getting injectable buprenorphine on our hospital formularies, and we're sort of starting that. We have them on the formulary now, and I would love that to be like a parting gift for people after they've been admitted for some, drug-related complication, and they want to have an injection as they leave, as sort of a bridge to whatever comes next. And I think this is the kind of data that really sort of emphasizes that would be a useful project for anybody who wants to, reducing readmissions. Actually, I'm about to put in a new request for Sublocade on the hospital formulary, so maybe I'll add this poster to the formulary request.
We would be happy to supply you with the data.
Can I have it really big? I want like the whole thing. I'm gonna roll it up and send it over through interoffice mail.
I might just put the actual poster in the tube and send it to Pennsylvania.
Yeah, exactly.
I do. So something that I just want to make sure all of our listeners understand that can be a real challenge with the long-acting injectable buprenorphine is that oftentimes when people come in the hospital for opioid use disorder, it's paid as a diagnosis-related group, which would be to say that the hospital gets a certain amount of money, no matter how much it pays to take care of the patient. And so if the hospital administers a long-acting injectable buprenorphine, which may carry a price tag of $1,000, they don't get paid any extra for that. So they end up eating that cost. Whereas if we can discharge the patient out of the hospital, let them walk downstairs to the office clinic that's downstairs, and then they have a regular outpatient doctor's visit, then we can bill the insurance the same way we would any other time that we would do a long-acting injectable buprenorphine.
Right. Makes total sense, but it's the kind of thing where you try to explain it to a patient and you just sound insane.
Yes, the patient's like, why can't I just get it up here, doc? I don't.
Right.
Yeah.
So sorry.
I mean, it's a great project. I think you should be congratulated on, developing the protocol, putting it into place, carrying it out, and then writing it up. I did see some journal editors kind of sucking up to you at the poster session. Are you going to submit it for publication?
So we have been waking up early and trying to type it up, and we've targeted a journal for it. So we're hopeful.
Awesome.
Nice. That's so awesome. Well, congratulations again. It's a great project, and congratulations on winning the poster contest.
Thank you for featuring the poster on your show.
Yeah. So, ready for the next poster? John, you want to tell us about one that you liked?
Yeah, so Sonya was very gracious to bootleg a copy of all these posters for me, who wasn't present at the at the conference. But a couple that we picked through. One is I thought were pretty relevant to I think what we see on a day-to-day practice. The title was "Higher Buprenorphine Doses Improve Treatment Engagement and Outcomes in Opioid Use Disorder." The authors were Chu Thornton, and I might mispronounce this, but Olatehu would be the other one. And it's really interesting. The study was kind of answering a question that I think a lot of us are seeing on a day-to-day. It said, in our kind of fentanyl era, does exposure to higher doses of buprenorphine impact adherence, retention, and overdose outcomes? And so this was just a retrospective cohort study of commercial claims data from 2017 to 2019. It was over 5,000 patients with opioid use disorder starting buprenorphine. And they kind of grouped people into 4 groups. So it was low, which was 4 to 8 milligrams of buprenorphine, moderate 8 to 16, high 16 to 24, and then very high 24 to 32. And the outcomes of that were predominantly treatment adherence, retention and care, opioid overdose risk. And it's kind of, I think it's what we're seeing on the day-to-day. The results kind of confirmed that higher doses were really associated with better outcomes in these groups. So better adherence, longer retention, lower overdose risk. And specifically, they looked at kind of steady adherence increased from 51%, so about half of the time in the low dose group, so that 4 to 8 milligram group, compared to the very high dose, which was up to 32 milligrams, where adherence was about 70%. Mean retention also improved substantially, so only 83 days in the low dose group, 156 days on average for the very high dose. When you compared the low dose therapy to the high and the very high dose in terms of risk of overdose, so there was a 32% reduction with the high dose group, and then with the very high dose group, it was a 57% reduction. So, I think the study really kind of shows, I think, what we see day to day. When I first started, I think, and same with you, Sonya, we talked about this before. I don't think I had many patients ever beyond 16. And I think that it was actually taught to me at one of my earlier classes that a patient never needs more than 16 milligrams, that the pharmacology doesn't make sense. But I think clinically, that's not what we see. And I don't know, my doses have gone much higher over the years, and people seem to kind of do much better on higher doses in many cases. And, I don't bat an eye at 24 milligrams anymore. I do have people beyond that.
Well, right. And I don't think I've ever seen a paper, at least not in the last 10 years, that shows that the higher doses are worse. Every single paper I see shows equivalent or better outcomes with the higher doses.
And
I
I think
think
medically
it's,
necessary, right?
yeah. Well, they're just safer. I think if we're looking at our big outcome of mortality and overdose, higher doses are safer for people.
Yeah.
I rarely have people go down on their dose. I mean, it's not not a never. Some people do kind of like a lower dose, but it's often in the context of tapering and trying to get off it altogether. People often just seem to feel better on the higher doses, or they request them, for whatever reason.
I've sort of evolved on this over time. But where I've kind of arrived working with patients, I usually say to patients, I'd like you on the lowest dose of buprenorphine on which your life goes well.
Right.
And so if that's 24 milligrams, that's fine. I mean, if you can whittle it down to 16 milligrams and be okay, that's even better. I guess a study like this makes me question whether I should even be doing that. But I still think trying to put the locus of control on the patient can be pretty good. And I think a little bit about how much buprenorphine I'm releasing into the ecosystem at one time. So people who are on lower doses, I tend to monitor them a little bit less carefully, actually. People on higher doses, I'll usually monitor them a little more carefully.
I guess I would never support diversion. And if I find a patient's diverting, then I definitely the prescribing has to stop. But I've seen data showing that communities with high levels of diverted buprenorphine actually are safer and have lower overdose risk than communities with less diverted buprenorphine. And so many of my patients have started their own journey in recovery with diverted buprenorphine. I have a hard time kind of worrying about it too much as a real danger to the community. So I actually don't think I monitor those patients any more closely. I do, though. I think it's worth it. Like you said, I'm big on reassessing, be it like any sort of prescribing, but like asking people, so you still need this medicine? Should we try to stop it? I won't like stop it, but like, hey, do you still need 24 milligrams? You want to try to reduce it a little? Like, how do you feel with this?
I think what Anthony said, though, is true, right? I feel like this is like one of the few locus of control that some of these people have in their lives. And so involving them in decision, even if you're not going to make a change, just kind of talking it through every so often, I think it kind of engages them. They feel empowered that they're part of the team and that you're working with them and in many cases, like for them, right?
Yeah.
So it's sort of funny. I have a question that I ask people about, sort of the question that's perhaps the best proxy for stability in treatment, I find, is I'll ask a patient on buprenorphine therapy, like, so do you have any strips left? Or do you have any medication left? And when a patient's like, yeah, doc, I've got about 10 or 20 saved up. Like that, I think that's a really good sign, actually. That's somebody who's kind of like thinking about their script and is pretty organized. And, I find that's somebody who's really adhering to treatment. Whereas like I'm a little bit more wary of somebody who sort of like sits patiently in my waiting room and then like lets me run like 2 hours behind. And then like I ask them, like, do you have any buprenorphine? They're like, I ran out 2 days ago. I'm like, no, like that's not
right.
That's not how you're supposed to do.
Well, right. I mean, you want people who are, I don't know, who are doing well enough that if they take an extra long nap, they skip a mid-dose, or if they go on an outing and forget to bring it with them, it's not a crisis. They do fine without it. So I think that was great. All right, you guys ready for the next poster? Okay, this one veers a little bit into the wacky. I apologize to the authors. That's not an insult. I really liked it because it's the first time I've ever seen anything like this. It was titled Naltrexone Treatment for AI Chatbot Addiction in an Adolescent with Autism Spectrum Disorder and ADHD. So this is the very first publication I've seen on chatbot addiction, although I've seen plenty on internet addiction, gaming addiction, social media, compulsive behavior, online gambling addiction, porn addiction, all these addictions. This is the first AI chatbot addiction. And I really enjoyed it because I've been talking a lot about AI. Everybody's talking a lot about AI. And we had a grand rounds recently from a local AI expert on the sort of psychopathology of being too connected to AI and how AI exploits the psychologically vulnerable. And so I just think the whole concept is really interesting. So this poster, the authors were Ridwan Mohammed and Lindsay Hastings Spains. They're from Lakeland Regional Health Center in Florida. It caught my eye, again, first published thing I've ever seen about AI chatbot addiction. We were just reading an article about how AI is going to replace primary care in 0 to 3 years. So I don't know, John, do you think you have like 3 years left before AI replaces your job?
No, I think we're good for a while.
Sometimes I'm like, AI, if they want my job, like, I'm like, be my guest. Take the job.
I mean, I could go on a whole tangent on this. I think the job is like, when you deal with people, it's like too unpredictable that it's just not the same. And it's funny, like, I think I've told you this before. Like, I often use like, I often use like AI for like I'm in my MBA right now. So I use it for my MBA homework and it's always right. Like 99.9% of the time. Whenever I use it to like do like practice questions, like when I was like doing my HIV exam, it was right like 60% of the time. Like the questions were just too nuanced for it.
Yeah. Well, and too new. Did you hear that the state of Pennsylvania is suing Character AI right now for practicing medicine without a license? Yeah.
I saw that.
It's going to be very interesting to see how that shakes out. But anyway, so this case study was about naltrexone treatment for AI chatbot addiction. So this is in a teenager with autism spectrum disorder and ADHD. So a very high risk of internet addiction in adolescents with both autism and ADHD. And AI chatbots have this like synthetic empathy and this self-reinforcing behavior, and they're primed to cause addiction in vulnerable people. So, I mean, just before I start, have either of you had a patient who came to you concerned about AI addiction or chatbot addiction?
I have not.
Not yet.
Yeah, I haven't. I'm not asking though, and it makes me wonder.
I mean, I've had people with serious bad AI interactions, like people who are psychotic and they're interacting with AI, staying up all night, chatting with AI about their things. which is not good, but I've never put it in the context or characterized it as like an addiction. So this case study, it featured a 14-year-old with a compulsive use of character AI, using it 4 to 6 hours daily. It impaired her functioning in school, her family relationships. She had 2 psychiatric hospitalizations triggered by her parents restricting her use of character AI. So really serious attachment to this product and destabilization when it was taken away from her. She was started on Naltrexone, 25 milligrams daily, titrated up to 50 initially. And Naltrexone, commonly used medication for behavioral addictions as well as other substance use disorders. We kind of seem to use it for everything. It's part of weight loss pills. We use it for alcohol, opioids, methamphetamine. It's kind of all over the place. It's used frequently for gambling and internet addiction. So, this case study, I'll just quote them directly. It says, the response was notable. Within 2 weeks, the patient reported a striking change in her experience. She no longer feels the large dopamine rush that she said when using the platform, and found herself getting, quote, bored in 5 minutes, unquote, which was a dramatic shift from her previous hours-long sessions. So eventually they did titrate up again to 100 milligrams daily. And the patient continued to do well with improvement in her depression, as well as improved functioning in school and at home. So I like this case study because it was totally new and it was very actionable. So like if I ever come across anybody with AI chatbot addiction, I feel like I know what to do. I'll try Naltrexone, starting at 25 milligrams and titrating up to as high as 100 if need be.
That's interesting. I feel like Naltrexone, use it for like any type of addiction at this point, is a trouble, just like the dopamine blocking effect, right?
It's like the statin, the Crestor of addiction treatment.
It certainly warrants it to try it, any kind of addictive behavior, try to get in the way of the reward pathways.
Well, that said, but then I end up not using it as much as I would want to because like everybody I know is on buprenorphine. So
I think something that's interesting is the authors of this study point out that the compulsive use was impairing function in school, family relationships, and causing psychiatric hospitalizations. And so, it's like a lot of people say, I'm addicted to my phone. But in order for us to really claim it's addiction, it has to really show loss of function, use despite adverse consequences. And I think that the authors demonstrate that was happening to this child.
Well, I think that's true. Like when you talk about phone addiction or internet addiction or people who are like doing too much screen time, it's like, what's the standard? You have to prove harm for it to be a substance use disorder if you're going to put it in that context. And they did a good job of characterizing that. But there's plenty of things that cause harm that don't reach the threshold for like substance use behavior or substance use disorder. It can still cause harm in some ways, but then there's a lot of arguing about what really is harm for these new technologies and our use of them. So yeah, congratulations to the authors. I thought this was an awesome case study. Next one, Anthony, you want to give us another one?
This poster was called Closing the Gap, Inpatient Methadone and Telehealth Opioid Treatment Program Enrollment. And the lead author was Michelle Breda, and then Sarah Taki and Alex Sidelnik are the co-authors. And the context here is that if we have a patient in a hospital, in just any hospital ward, and that patient has opioid use disorder, but is not enrolled in a methadone maintenance program or an opioid treatment program, and that patient needs to, say, go to a subacute rehab facility or a skilled nursing facility, it is a very big administrative challenge to get that person onto methadone and send them to a skilled nursing facility.
Yeah.
Yes, it is.
And so the purpose of this poster was that they describe a series of 9 cases where they were able to do the opioid treatment program enrollment while the patient was in the hospital. And so I'll detail how they did that. So they had a multidisciplinary work group, and it was formed between NYU, the hospital, and a local methadone program, which I happen to know is Greenwich House, which is a storied methadone maintenance program or opioid treatment program in Lower Manhattan. And they leveraged new regulatory changes to the final rule. And their workflow was that they would have the patient with opioid use disorder who was admitted. They had an addiction consult service consulted, and then the patient would be initiated on methadone, and then they would go to a post-acute care facility the opioid treatment program was notified and an admission appointment was completed, and then the patient gets transferred to the facility. So, the sort of big question is how. I mean, I'll first say what they did, and then I'll talk a little bit about how they did it. They did their first telemedicine admission in 2025. They've done it 9 times. 7 of the 9 patients were successfully discharged to the planned location. They didn't specify what happened to the other 2. But then of those 7, 5 returned to the opioid treatment program after they got out of the nursing home.
Mm-hmm.
Now, there were some challenges with this, but they were able to do it partially because they had one doctor who was credentialed at both the hospital and the opioid treatment program. So that doctor was able to practice in both locations. And that required a fair amount of administrative review just to make sure that it was legally compliant. But they were able to do it. So, in conclusion, I think that this shows that if we think creatively, we can overcome some of these very big sort of American barriers to opioid treatment, particularly with methadone.
Well, it's just one of these things that, like, if you tried to explain it to a person who wasn't an addiction medicine provider, they'd be like, well, why can't you start methadone in the hospital and then give it when the person's in rehab? Like, they're in rehab, it's being dispensed. They're not going to like run away with it. They're all doctors. You can prescribe methadone for pain. Like, you have to have this very special situation and a million rules. And I don't even want to know what the committee meetings were like to try to set up this protocol.
I know, right? That's gonna be miserable.
Oh my gosh. It's like the regulations are so burdensome and non-intuitive.
Yeah.
I love hearing about this stuff, and then it makes me kind of sad because it was like so difficult to do something that seems so simple.
That's right. And this sort of heroic effort is what should be common practice everywhere. But you can just imagine, like, could every hospital put this together and have a methadone, opioid treatment program that would be willing to work with them? It's a little aspirational.
I mean, they could, right? So, I mean, the answer to that is they could. I think they do some pretty crazy things, very outside the box thinking for other areas of medicine, right? I feel like this one is one that definitely warrants it. There's lots of barriers to care. And I feel like I just wish that there was more incentive to kind of put people to think outside the box like this.
Well, it's true. We do all kinds of wacky stuff with some of our, like we've got teleneurology doing, critical stroke care at our smaller hospitals. And we just set up these community hospitals that don't have a doctor in them. It's all telemedicine hospitalists. There is no
That's
doctor.
right. Maybe a mid-level provider stations.
No, they don't.
Or not. No,
Wow.
no. There is no. It's just
Wow.
nurses and the doctor on an iPad.
Wow.
Anthony, I don't think we told you John's like sort of an administrator, so he loves all that stuff. But it's like we do. You're right. We do all kinds of outside the box thinking, and except not in addiction medicine. Right. Because there's just so much stigma, and God forbid, I don't even know what people think will happen.
Well, I think it's sort of interesting from a regulatory standpoint because a hospital has a hospital grade pharmacy, and so the methadone can be tracked, which is part of the reason why we are allowed to start methadone in an inpatient setting. But you can imagine that like a subacute nursing facility might not necessarily have the requisite storage for doing the methadone. They might, but it's less clear.
Yeah.
Right.
It's interesting. I love hearing those types of projects, though. It's a really good article to highlight.
I know. Good work, everybody. All right, John, you ready to keep it going? Got another poster?
Yeah, kind of an interesting one. This one's called Increased Naltrexone Prescribed for Alcohol Use After Change to Obesity Treatment Protocol. And it's by Sazagar and Martinez. And I think it's a really interesting idea because I think that a lot of people have interest in obesity medicine. And I will say, like, especially with the advent of the GLP-1s, I'm not going to steal anyone's thunder talking about GLP-1s tonight, but I think a lot of people find that work really rewarding and we have an effective medication there. And I think now it really feels like it's back in the scope of the average, primary care physician. So, it's interesting. It's a stigmatized disease as well, obesity in many regards. And so the kind of this overlap of treatment between medications for alcohol use disorder and obesity kind of gives an opportunity for maybe even some more leverage of use of some of these meds. This was specifically increased awareness of obesity medications to help with alcohol use disorder, looking at naltrexone. And this was a quality improvement project from Kaiser Permanente. And the initiative was to increase PCP prescribing for naltrexone, and it was for both for obesity and for alcohol use disorder. But this was looking specifically for the alcohol use disorder. And like many of these Kaiser studies, it's really a QI project more so than a study, but it's a practice improvement project launched in 2023, and it's from the San Diego office. And the intervention included PCP education, an EPIC decision support tool, which I feel like every time that we have a problem now, the answer at a meeting is like, we can make a smart set for that. So it's like, it seems like that's become like, if you want to just throw an idea out there that, will be taken seriously, it's like smart set or leverage AI. Seems to be like the two easy buttons. Yeah.
Okay. Can AI make the smart set? I want to leverage AI to make a smart set for prescribing GLP-1s.
Probably could. They had follow-up messaging, and then actually they had a formulary change that linked the prescribing of naltrexone to not just only alcohol, but also obesity diagnosis. So they kind of changed their formulary to include this. And they did basically a pre and a post analysis from the 2 years before and the 2 years after they made this quality improvement initiative. A little bit about the results. So 70% of PCPs attended the live education session. The total naltrexone prescriptions for alcohol increased. There was 420 the first year, and it went up to 1,000, almost 200 by year 4. So that was basically a threefold increase over the period of this quality improvement project. The number of PCPs that prescribed naltrexone went from 191 to 327, which I think is awesome. So it kind of went into the armory of almost a double the amount of physicians there. In terms of high volume prescribers, and they define that as like PCPs that prescribe greater than 10 patients per year. Naltrexone, it increased from 7% to 26%. So it's for alcohol use disorder. There was an overall threefold increase in naltrexone prescribers, patients treated for alcohol use disorder, and high use or high volume prescribers. Interestingly, they kind of used acamprosate as a control here, so that wasn't linked to an obesity diagnosis or a change. And really, throughout this kind of period of time, there was actually no change in acamprosate prescribing. So it really they kind of use that as the control, using the obesity diagnosis as kind of like the intervention here. So I think it's interesting. I think with the combination of specifically naltrexone, but also like GLP-1s kind of showing efficacy both for weight loss and then also for substance use disorder, I do wonder if, clearly a QI project like this could be useful, but I also think it kind of highlights the willingness of like PCPs and general practitioners to step into this space when these medications also are concurrently used for obesity. It seems like there's like a higher comfort level.
Right.
So hopefully this is a sign of things to come.
So in this study, if a patient had either obesity or alcohol use disorder, then like a smart set popped up suggesting naltrexone, or with both?
The way it sounded from reading it was that there was an EPIC decision support tool, so a smart RX for basically alcohol use disorder, but that the naltrexone was also linked as both kind of approval for obesity and for alcohol use disorder.
Right. It's so funny because it's just like psychological for the PCPs. They're like, I could treat obesity. So they'll use the medicine, even though they're like, I don't want to treat alcohol use disorder, even though it's the same drug and kind of the same like dosing and everything.
Yeah. I mean, I think we all see that every day, right? I mean, how many people do you see that they go like, you got to go to somewhere else for that, even though they do way harder things in medicine. They prescribe opioids for pain, but they don't feel comfortable with buprenorphine. They prescribe, naltrexone or GLP-1s for obesity, but they don't feel comfortable treating the same patient with alcohol use disorder. I mean, it's stigma, but it's interesting that, it is stigmatized. But at the same token, it's optimistic to me that, when you link it to the obesity diagnosis, that people are more willing to step into this space, right?
Mm-hmm.
The future's brighter.
Yeah, it's just we got to wait for like the old people to retire. We'll get the young people up to take over.
I will say, I work with the students and the residents, and they, in the past like 10 years I've been here, I'm coming on my 10th year, the students and residents are incredibly interested in this topic, and they're incredibly engaged in this topic. And they love the lectures. I always get really positive feedback. I get asked to come back to do more. So I think that they do thirst for this a little bit more and treat this more as a disease, as, and not to be ageist, but certainly, I think some of the older, closer to retirement physicians are just kind of burnt out with this, and they don't feel as much of a love. That's very generalizable, but I mean,
I will say I've definitely observed that resident trainees were really hungry for the addiction lectures, and I do believe that it is becoming increasingly accepted that addiction medicine should be part of every trainee's training. We could discuss the degree to which that's true. And I think that's driven somewhat by the trainees. The trainees be like, I can't practice in a future medical environment if I don't understand these topics.
Yeah, totally.
I'm a family doc. They added it. It's an ACGME requirement now. They graduate with some familiarity with medications for addiction treatment.
Internal medicine as well.
Right.
It's awesome.
Yeah, family practice, I feel like, really has led the charge for treating addiction medicine. Internal medicine does some and psych does some, but, family practice, I think like a lot of areas in medicine, provides the bulk of the care when you really look at numbers. So thank you, guys. All right, I have one more. Let's see. It's not too late. You guys ready for one more from me?
Yeah, let's do it. Sure.
All right. So this one I mostly liked. I loved it, but I had a really awesome conversation with the authors. So that kind of made me feel even more warmly about this poster. It just presented some really interesting data on a theme that John and I have covered a bunch of times. And Anthony, you can tell us your perspective on this, which is smoking tobacco in patients with substance use disorder. So this poster was titled Comorbidities and Mortality in Substance Use Disorder in Patients with Nicotine Dependence. Doctors Lee and Dr. Eluze, and Dr. Singh, all from the University of Texas Tyler School of Medicine. So before we start, do you guys bug your patients with addiction, substance use disorder, about smoking cessation? Yes? No?
Yeah, I'm a primary care doctor first. Like, I feel like people hear a lot about smoking cessation.
Yeah. How about you, Anthony?
Are you talking about in the hospital, or you're talking
all the
about
time,
in the outpatient?
All the time.
Anytime. I lurk listening, and the second the subject comes up, I start to ask people about it. I don't always lead off with that. I feel like I'm trying to see what a patient's agenda is for the day.
That's probably wise.
By your setting, right? That makes sense.
I've developed some pretty funny responses. Sometimes the patient will say to me, Doc, I'm thinking of quitting smoking, and I'll be like, why? And people look at me like I'm crazy, but I actually, it's sort of a motivational interviewing trick to try to get them to convince me that they want to quit smoking. I said, great.
Oh my gosh. Right.
Sometimes I just start the visit by congratulating them for quitting smoking. And it works like 1 out of 20 times. I'll be like, you're right. We do need to talk about that.
That's nefarious. I totally bug patients about it. I'm in sort of I don't know, maybe I'm just in a mood these days about the evil of tobacco, and I just can't stand it. I cannot stand seeing people ruining their lives with tobacco. People have struggled so hard to quit drugs, and then they continue to suffer from tobacco use disorder, but there's no sense of urgency to quit, unlike with opioids or stimulants. But I just hate how bad it is for people's health, and I also hate seeing people spend their limited resources on it. That's another thing that just bugs me. I was looking it up. So a pack of cigarettes in Pennsylvania is $11.85 on average right now. And the state median household income in Pennsylvania is $77,500, which is pretty high in PA. But it's, of course, most of our patients are way below that. So if you have a pack-a-day smoker and you're at the median household income in Pennsylvania, you're spending 6% of your net income on tobacco. And of course, most of our patients are way below that. almost all my patients have Medicaid. For a single person, it means your annual net income is below $21,500 in our state. So that would be spending an average of 20% of your income on tobacco.
Well, that's
Which is
remarkable.
terrible. And there's so many things they could do with that money that would help them out, rather than smoking. So I really do feel it's an evil product that like robs you of your health and your resources. And so I don't know. I'm probably annoying about it. But cigarettes really piss me off. So um, I always like data on smoking cessation in patients with substance use disorder. So this was a retrospective cohort study. Looked at the rates of medical and psychiatric problems in patients with substance use disorder and nicotine dependence, or both. And so without going into all the numbers, basically they found that the combination of nicotine dependence and substance use disorder led to higher rates of medical and psychiatric diseases and mortality than the sum of each alone. So basically they were synergistic risk
Mm.
factors. It wasn't just additive. Adding up the risk factors, you got even more than if you did either one alone. So some specific numbers: cardiovascular disease present in 19.5% of the combined groups, but only 9% in patients with substance use disorder and 7.6% in patients with nicotine disorder alone, but the combined was 19.5%. So synergistic. Also true for respiratory disease, psychiatric disease, neurologic disease, infectious disease. And finally, mortality in substance use disorder during their cohort, 1.7%. In the nicotine dependence group, 1.3%. And just to note, the nicotine dependence, cardiovascular disease, and mortality is lower than substance use disorder, but that's not over a patient's lifetime. That's just over this study, which was a more, it's like a shorter time frame. I think it was like 4 years or something. So mortality, 1.7% substance use disorder, 1.3% nicotine dependence, and in both groups together, it was about 3%. So overall mortality, it was additive, not synergistic, but given that tobacco kills you much more slowly than other substance use disorders, I feel if they were to continue to collect data beyond the 4 years of this study, the tobacco-related mortality would likely start to rise. So again, just reinforce something to me that I kind of sensed that I felt from seeing my patients, which is that the combination of substance use disorder and tobacco use disorder is like extra bad. And I know for me, I can't watch it. I can't just stand by. So I'm always talking to my patients about quitting smoking. And I don't force them. I always say, would you be interested in quitting? And if they say no, I say, I hear you. I understand. Just so you know, we have these resources to help when you feel ready. And then I just continue to bring it up over and over again. So
Yeah. Well, I think something that's sort of interesting is patients will often say, "Doc, I've given up opioids. I've given up alcohol. This is the only thing I have left." And that presents an interesting treatment moment for us docs, because we have to ask, like, so should we validate the patient for that? Or should we sort of nudge them on the tobacco? And as this poster suggests, and I think some prior studies have suggested, in fact, when people can quit the nicotine dependence, that actually seems to improve the overall SUD recovery as well, or at the very least does not harm it, despite what patients sometimes tell me, like, no, there's no way.
yeah. I mean, I push back on that a little bit. I validate that they've done amazing and I congratulate them on all the progress they've made. And I say, but, just for your information, of all those 3 addictions, the tobacco is the most lethal.
Yeah.
It was less urgent because it kills you kind of slowly, but it's the most lethal. 60% of smokers die from smoking related illness. 60% mortality of this habit. And so I say, as someone who continues to care about your health, getting rid of this would be the final step in really living a long and healthy life. So I'm not going to force someone to quit smoking. I don't silently agree by accepting that it's a good trade-off. I don't know. It's kind of, as I said, I'm really irritated at the tobacco industry right now. So I'm pushing hard. Sounds like you might not be quite as irritated and maybe you're a little gentler with people.
I feel like, that when I have people like when, in remission for a longer period of time that are doing well, I feel like I see them so frequently. I still see them very frequently compared to my average patient. I feel like at some point I'm like running out of things to help them get healthier at the visit. And then I'm like, all we got left is the smoking. So I feel it's
Yeah.
kind of hard. I don't have other, like, because they're like, they'll talk about their other things going in their life and everything's going well at some point, and they don't have any really barriers. And this isn't everyone, but I do have patients I've been taking care of for like 6, 7, 8 years now. And the only thing we have left to talk about is the smoking. And then every couple of years, we'll talk about like their getting their Cologuard and getting their pap smear. But
Right.
that's only a once in every 5-year
Right.
conversation.
Right. And what's worse, talking about smoking or trying to make people exercise and like eat more vegetables,
Yeah, I also think, as John alluded to, when we have a patient on buprenorphine therapy, we're going to see that person maybe 12 times a year or something like that. Not sure that they have to be nagged about the smoking 12 times in the year. Like, it's just I'm lying and waiting, and then it invariably comes up at one of these visits, and I say, well, so you're thinking about quitting smoking, and when they bring it up, I actually find that then we can pounce, and that
Yep.
I that's how I maintain my sanity, because otherwise I feel like I would just be hassling people, wasting valuable minutes in a pretty busy.
Oh my
Yeah.
God. Or don't see them 12 times a year. That's like way too much. So that
This
was
is
my
fun.
last. Yeah. So wait, we have one more. I think I wanted Anthony to bring us home with a final
my gosh.
poster.
I guess I would do
Unless
one.
unless you're
gosh.
done.
So the poster that caught my attention was Real-World Analysis of Buprenorphine-Precipitated Opioid Withdrawal, a Multicenter Study. And the presenters here were Rachel Culbreth, Paul Wax, Timothy Wygand, and Kim Aldi, Alyssa Felice. Oh, wow, there's a lot. There's
Oh,
wow.
Sharon Kaplan.
So many people.
And Jeffrey Brent. They weren't all presenting authors. So the background on this, I think that this this poster aims to address this concept of buprenorphine precipitated opioid withdrawal. And this is a tricky disease entity, because any addiction doc who's been doing this for long enough will have seen a patient experience this. And it's a scary syndrome. Like when this happens, it's like very serious. And people often walk out of the hospital. They often say, buprenorphine, not for me. I must be allergic to it or something. This is a bad condition. But there's no great agreement on how to prevent it. And there's no great agreement on the best approach for starting buprenorphine in the fentanyl era. And there were some pretty big studies. There was a big study about a year and a half ago coming out of California which was an emergency room-based study, where they noted the rate of buprenorphine precipitated opioid withdrawal is very low, like a few percent or something like that. And they had the numbers to support that. But people on the East Coast with whom I spoke were like, how can that be?
Yeah.
That's not what we see at all. And so here we have a multi-site study, some of the sites being on the East Coast, where they go retrospectively looking for buprenorphine precipitated opioid withdrawal on the record. And so the analysis was conducted using Toxicology Investigators Consortium. They did some chart review of de-identified data. The outcome of interest was if there was any noting of precipitated opioid withdrawal in the chart. And then they looked at demographics, first opioid dose, first buprenorphine dose, initial dose, and other demographic information that they then performed a regression analysis on. So they had data from 36 institutions, 17 states, as well as 3 international sites. And they identified 1,465 patients. 463 were initiated on buprenorphine during a hospital visit. Of these 463 patients who they examined, there were 60 buprenorphine precipitated opioid withdrawal events for a overall rate of 13%. And they didn't find any statistically significant difference between age, sex, race, ethnicity, prior medications for opioid use disorder, or drug screening results. there were statistically significant differences in the first buprenorphine dose, such that the group that received the higher doses of buprenorphine, 8 milligrams or greater, compared to lower doses, 4 milligrams or lower, the higher dose group experienced more buprenorphine-precipitated opioid withdrawal. And so they conclude higher doses of buprenorphine for the first dose were associated with suspected buprenorphine-precipitated opioid withdrawal. And they say that this can inform the way that we all go about starting buprenorphine for our patients. So, I mean, I'll turn that over to you guys for discussion. I think it's very interesting.
So for them, the higher doses were associated with more precipitated withdrawal.
Interesting.
But overall, it was still a relatively low rate.
Yeah, I mean, I'd say it's 13% is at once not that much and an awful lot.
Yeah.
So like, I mean, I'm admitting, generally speaking, about 10 people a day, 5 of whom might be opioid dependent. And that means that every few days I'm going to see this. The West Coast article that came out was endorsing a macro dosing approach. So give very high doses of buprenorphine. And many of us on the East Coast were doing a microdose type approach, or a low dose buprenorphine induction, and wondering how is it possible that they could be doing the high doses and not seeing the precipitated opioid withdrawal syndrome. And I think that this poster is very validating because it said, in fact, it probably does have something to do with it.
Do you think there's any difference? Like I've heard people say one of the problems with precipitated withdrawal is it's hard to sort out what's just withdrawal and what's precipitated withdrawal, because you can be having regular withdrawal and then it just gets worse as withdrawal does. And the lower dose buprenorphine doesn't really treat that withdrawal as well, whereas the higher dose buprenorphine actually treats the withdrawal better, even though it has a higher chance of causing precipitated withdrawal. So sometimes it's hard to sort that out. I don't know if that plays into sort of the different concepts of what is effective for preventing precipitated withdrawal.
Yeah, that's a real challenge. I mean, I can speak to how we do this in the inpatient unit, which is like very different. It's like a real luxury to be able to do this in the hospital instead of like in the outpatient setting where we say, "Here's some buprenorphine, like go home, try not to get hurt." But I'll tell you our protocol, which has been working pretty well for us, which we hope to publish in poster.
More posters. So many posters.
Yeah, because the posters. But we offer methadone on day 0 when people come in, usually about 30 milligrams. Methadone on day 1. And then we stop the methadone and we use buccal buprenorphine off-label on day 2, which we are able to do because we're a hospital, so we don't butt up against the regulatory barrier. Because buccal buprenorphine, better known as Belbuca, is considered a pain medication, not an opioid medication. So it's a little bit of a violation of the Harrison Narcotics Act to prescribe Belbuca for a patient with opioid use disorder. But in the hospital setting, that's irrelevant. So we use that at the 150 microgram dose, and we offer that every 2 hours. But I think what's interesting is, so when we challenge a patient with the buccal buprenorphine, we will ask them, after you took that dose, were you better, the same, or worse? And when they say I'm better, we know we're winning. If they say they're the same, we're pretty happy with that. We say, okay, take another. But if they say, I instantly got worse, then we tend to think that we're actually precipitating withdrawal even with these very low doses of buprenorphine.
And then you back off and wait a little while longer, or?
Yeah, that's right. We'll sometimes actually treat with a full agonist, like an oxycodone or hydromorphone for a day, which again is a luxury we can do in the hospital, but in the outpatient setting it's more difficult.
Of course. Well, it's just super interesting. I mean, spoiler alert, the next article I'm going to present for our regular journal club is on like direct to inject long-acting injectables without any like test dose sublingual buprenorphine. And they had like the same rates of precipitated withdrawal in that study. It was like, I don't know, I want to say like 11% of people had severe precipitated withdrawal. I'm just receiving a buprenorphine injection cold. So it sort of lines up with that. But
I agree with you though. Go for it.
It is hard. I mean, I don't do a ton of buprenorphine initiations in the outpatient. Like patients are already on it, or they initiated themselves with illicit buprenorphine, or they're coming from another doctor. But even with me not doing a lot of brand new initiations, I've had 2 severe episodes of precipitated withdrawal this year. 2 that were from medicines I gave, and then another one, a medicine someone else gave. And all 3 patients ended up, I think, in the hospital. One of them intubated, actually. Although it wasn't
Wow.
buprenorphine-initiated precipitated withdrawal. It was naloxone precipitated withdrawal. But
I kind of agree with you. 13% is kind of high. I think for something that could push someone away from treatment altogether, it's interesting. I still struggle with this. I mean, I feel like I'm seeing equal parts now. Yeah, either go really, really low dose initiation, or you're right, the other articles about like just hit them like as hard as you can up front. But there's nothing in between. I will say that I think the one takeaway that's overlap that's common here is it seems like that 8 milligram middle dose is like the danger zone.
yeah, that's like the worst
right?
dose.
I think that's like,
Yeah. Actually, I've heard it said that 4 milligrams. 4 milligrams is just the dead wrong dose. It's like absolutely enough to make somebody very sick and not enough to provide them any relief. And to John's point, 8 milligrams probably similar. I will sometimes pitch this to patients, and I ask them if they want to start low or start high. It's sort of like, are you the kind of person when you go to a cold lake, do you ease yourself in?
Oh, I
Or
like
do you
that.
jump off the dock?
Right? That's a good metaphor.
That's a good one. Yeah, I like that.
Because it's also, you just get it over with. Like, again, I feel like I'm talking about next week's article, but like, of the patients who experienced like severe precipitated withdrawal in this study that I'm going to talk about next week, 80% stayed in treatment and returned for more,
Yeah. I have a colleague in New York who had a poster at a prior conference. Is Dr. Linda Wang, and I do think that something I've heard from her group is that like patients may precipitate after a long-acting injectable shot, but like that's not necessarily the end of the world. Like they, if they have the right expectations, like look, you're about to do a hard thing. Like people who are have cancer and going in for chemo are well aware that like this is a life-saving treatment. It might make them a little sick, but they'll get through it. And so, with the proper expectation setting, perhaps we can help people through moderate grade precipitated withdrawal that's triggered by the shot.
Gosh, that's a lovely thought to end on. John, do you want to take us out?
Oh, thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about our article included in a future episode, send us your comments on social media, email, or join our Facebook group. The links are in the show notes. Original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from MyCares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation and have a great day.